CIHQ for being a valued partner of ours and giving us the opportunity to discuss this important topic today. So my name is Mia Kulik, and I'm the Director of Partnerships here at Voice, and I'm excited to be with you today. I'll pass it on to Danielle.
Hi, everyone. My name is Danielle Meter. I am the Director of Organizational Quality and Partner Success here at Equiti, and I'm also a nationally certified American Sign Language interpreter, and I'm really excited to be here today, so thanks for having us.
And hi, everyone. This is Tatiana Sestari. I am the Director of Language Service Advocacy here at Equiti, and my background is in pharmacy and pharmacology, and I'm also a nationally certified healthcare interpreter for Spanish. I'm very glad to be here. And with that, I'm going to share my screen so that we can start talking. All right. Okay, I'm sharing the screen now. And just a second.
Wonderful. There we go.
All right. So we're here together to talk about language access as the first social determinant of health to solve. And I am going to actually pass the next slide if you already saw our faces and we introduce ourselves. And today we don't have a lot of time, but we're going to try to talk about many different things that have to do with language access services and certain considerations for compliance when you're trying to provide language access in your facilities. We'll talk about good practices and how language access is a social determinant of health and also a way to address other social determinants of health. And we're also going to talk about some strategies that are important when it comes to providing equitable language access. So with that, I'm going to, before that, oops, where did my other slide go? Oh, okay. Before we do that, I'm going to actually stop sharing my screen for just a moment so that you can see our faces. Okay. So you shouldn't see our slides, right? So let's set the stage. So we're going to pretend Danielle is a doctor and I am the patient and I'm coming to see the doctor. Doctora Daniela, ¿cómo está el día de hoy? Mire, yo vengo hoy con un dolor de cabeza horrible. Yo no sé qué está pasando porque yo llevo tomando estos medicamentos que usted me dio y realmente no sé qué hacer. Cada vez los dolores de cabeza son más fuertes, no aguanto, no he podido dormir, no como bien, me da náuseas, me da vómitos, todo eso. No sé qué hacer.
I'm sorry. English? I don't understand anything you're saying. I'm so sorry.
No, yo no hablo inglés, quizás un poquito. La puedo saludar. Hello.
Hello.
Pero,
yes, there you go. Is that? Can you speak English good enough so that we can get through this?
English. My head.
Okay.
No sé, es que tengo mucho dolor, no sé qué hacer. De verdad, es horrible.
Advil? Allergy?
¿Alergia? No alergia, no.
Okay, all right. So your head hurts.
Pero que tiene que ver alergia con mi dolor de cabeza. Yo necesito tomar medicamentos o dejar los medicamentos, o sea, no sé qué hacer.
I'm sorry, I can't help you.
You said you can't help me?
Can we, I know, Google Translate, does that work? Google. Okay, headache, no allergy, Advil, Tylenol, see? Headache.
¿Que si sé qué? Mi cabeza.
Sí. ¿Sí?
¿Sí? Que si veo algo, sí o sí. No le entiendo.
Sorry. That works, right?
Thank you.
In reality, that works. And unfortunately, for some folks, they will go to Google Translate. And if we're thinking about equitable healthcare and taking care of people and positive health outcomes, Google's probably not the solution here. Hopefully, we're never using Google, which is why we're going to talk further about the strategies to address this SDoH.
Absolutely. So, thank you. All right, so I'm going to share my screen again. You should be able to see the
You can see
slide.
it currently.
And that feeling and that situation that we just showed you is probably the situation of at least 8% of the population here in the United States. We have, I would say, as you see here, if you look at the graph on the left-hand side, you have percentage of population versus time in years. And as you can see there, almost 10% of the population expresses to knowing English less than very well. So that's a good number of millions of people that are in a situation like that in this country. And since this data is until 2019, we wanted to bring data that's more current. And just through the end of October, as you can read here in 2023, almost 207,000 Cubans, Haitians, Nicaraguans, and Venezuelans arrived to the United States lawfully and were granted parole under the parole processes. So this is happening every month, every year, and not only from these countries, from everywhere in the world. So we need to consider those numbers and how those affect us as healthcare systems, hospitals, clinics, etc.
Yep. So let's first define a couple things. Let's start with SDoH, social determinant of health. We know of them, but what does it actually mean? And what we have here is based on the World Health Organization and defines an SDoH as a non-medical factor that will influence health outcomes. They're the things that prohibit people from being able to do what they need to do, to be able to be active members in their community, their jobs, their homes, their families. And oftentimes when you think of an SDoH, language access doesn't even register. We think as someone choosing between spending their money on healthy food or medications, transportation to get to their job versus transportation to get to the doctor. And so these barriers prohibit them from actually making healthy choices all around, or even having a choice to do something that they need to do for their health. And we believe that language access, one, is certainly an SDoH, and second, is the easiest one to solve. So when we have full access to what someone is saying, feeling, thinking, and experiencing, we can identify all the other social determinants of health that a person might be experiencing. That's why real communication needs to happen. That's why pointing at my head and going, no, have a headache and no allergy is not nearly enough, because let's say I do get to the root of what Tati was struggling with, but if I'm not working with an equitable language access solution, I may not know that she has housing and food insecurity, that she has other habits in her life that are going to impact her health that we would love to address. And so as it says here, we know quality of care is lower when patients do not understand what their healthcare providers are asking or telling them. And the same with healthcare providers. If they don't know what's going on with that patient and everything that impacts their health, then we're not going to have the best outcomes possible, because we only get to see a snippet of who this person really is and what they're experiencing and what challenges they may be going through, that providers have resources available to help bridge those gaps and get them as healthy as possible. We know low literacy is certainly an impact, and you're going to have low literacy if you don't have equitable language access. And you hear us say equitable language access a lot. It's a real value when providing patient health care. You want to make sure that they have access, and they have access to everything as though they spoke English. And that takes a lot of strategies to do that, but it ends up and results in healthier communities, healthier patients, healthier families. If we go to the next slide, we'll give you another definition that we really like to talk about. Actually, I got ahead of myself. We'll talk about some of the disparities that first come with SDoH. So go ahead to the next slide for me, Tati. Thank you. We know the disparities that exist and often are attributed to language access and a barrier to language access. So we know that the LEP, the limited English proficient patients, often experience things that are not as common or at a frequency that English-speaking patients experience. So we'll see a 46.9% increase in the risk of a 30-day emergency visit. That's going to the emergency room and then having to go back at a 26.7% readmission. And that often can be attributed to the fact that the discharge instructions may not have been in their language, either through an interpreter or translated material, or an interpreter wasn't used the entire time, and so not the entire scope of that patient's emergency was identified. The length of stay can be longer, and it's not because you're working with an interpreter, it's because you're not working with an interpreter or other language solutions, because it's taking longer to get to the root of the problem for that patient or longer to understand their history and the best path forward. We see higher rates of diagnostic testing in the emergency department, higher rates of hospitalization, and there's an increased incidence of physical harm, more severe than what folks who are speaking English might experience. And again, it might be because there's a lot of assumptions happening that we're using an interpreter, or I should correct myself, working with an interpreter instead of working with an interpreter less frequently, or in fact, working with an unqualified interpreter. We like to say bilingualism does not an interpreter make. I am a nationally certified American Sign Language interpreter. I speak English and I speak Italian. That doesn't mean my Italian is good enough to be an interpreter. And there is a distinct difference between being fluent in a language, either as your madrelingua, or being fluent in a language because you've picked it up. And so even if someone knows Spanish, Italian, French within the healthcare environment, it doesn't make them a qualified interpreter. So you may think, well, that was language access, but was it equitable language access? And was it a way to provide complete access so you could identify all the other SDoHs that might contribute to any number of these things we're seeing here on our screen? So we go to the next slide. What is the value of providing those language services? What is the value besides lowering all those statistics that we just saw? Well, the value of providing it is that you have a door, a portal, a window into all the other social determinants of health that impact patient care. And another term we use here a lot besides the ones we've talked about is communicative autonomy. It is one of our favorite terms that we get to talk about because it is the essence of the role of an interpreter and the essence of what we all really desire. So what does it mean? Communicative autonomy is not an interpreter or language access specific term. It's actually something that applies to all of us, and it means we get to say what we want, when we want, how we want. I have it right now as I'm talking to you, and I'm catering my conversation to the topic and the audience and why we're here today. When I'm at the grocery store, or I'm at the doctor's office, or I'm at a party, or I'm anywhere, I get to say what I want, when I want, how I want, which means the presence of an interpreter should not impact that. And so when we train and work with interpreters here at Equiti, we talk about that is the essence of their job, and that every decision we make can be rooted back to did everyone, patient, provider, family, anyone in that encounter and that experience get to say what they want, when they want, how they want. And did your decision support that or hinder that? Well, that goes for the providers, that goes for you too. If you can't communicate freely with your patients with an interpreter or other appropriate language service solution, then you're not able to do diagnoses, counsel, help rehabilitate, therapeutic support, because you're only getting access to a little bit, not the whole picture. And we know when patients and providers both get to experience communicative autonomy, we have equitable language access. We have authentic relationships. We have real understanding of the patient experience, which goes back to why we truly believe language access is the first SDoH to identify and solve for, and quite frankly, is the easiest one to solve for. There's lots of things that impact patient care in the clinic setting and outside, in their communities and in their homes. But providing an interpreter, translating documents, any number of language access solutions are readily available and easy so that you can address everything else, so that your patients and you can say what you want, when you want, how you want, and you can have better outcomes. You reduce that readmission rate, you reduce that length of stay. They go back to their homes, and the thing Tati loves to talk about is the reputation of the place they got support in. Knowing that if I go here, they call these interpreters, they have this translated material, that's the place I'm going to tell my friends to go to. That's the place I'm going to go back to because I know they're taking care of me as the whole person. And it starts with being able to communicate. Now, it all sounds nice, warm, fuzzy. Yes, I want to provide interpreters, but of course, there's some laws to make sure that happens. We have the Civil Rights Act of 1964. We have the Americans with Disabilities Act, which primarily applies to the deaf community. So I am Italian and I'm a sign language interpreter, so you've seen my hands flailing about for the past few minutes. But the deaf community certainly has a right to language access, and that's built into the ADA. That's also built into the Affordable Care Act of 1557, which has gone through versions and iterations. Tati is our resident expert on it, and it really dictates how we are supposed to provide that equitable language access, whether that is through qualified interpreters, making sure patients and families are not asked to or forced to use their family members. Minor children are not asked to or forced to provide interpreting services. And it takes that responsibility off the family so the family can just be family, as well as your bilingual staff, making sure that they are qualified to provide interpreting services and that people are wearing one hat at a time instead of having to wear multiple hats with competing priorities, right? And that no one faces discrimination on the ground of race, color, all of these things we see here. We talked about the folks who have been arriving in the United States, no matter what means they come to the country, the laws are here to protect them so that they can go to the hospitals, go to the clinics, and get language access. So you can identify what other things might be impacting their health experience and their health journey, and how we can help them and make sure you get to do your work and serve your communities. Okay, that was a lot. All right, so how do you do this? You have the responsibility, you have the laws that dictate, and you know why you have to, but how do you do that? And how do you do it correctly? Everybody can finger in the air and go, I think we should do it this way, and I think we should do it that way. Well, fortunately, we have national standards for culturally and linguistically appropriate services. That's a really long title, but that really gives you the guidelines and the guidance on how to execute on our responsibilities. And so what that says here is provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. Health literacy is not just an issue or a challenge for people who don't speak English. It's a challenge for everybody, but now add that layer of language access. So having plans, policies, procedures, it doesn't mean you have to have everything right out the gate, but at least having a plan and a path forward to make sure that your plans and policies reflect the law, reflect your communities. The communities that you serve are different depending on where you might live in a city and or in a state. I'm in Raleigh, North Carolina. We have a North Carolina has a large Honduran community. I used to live in Minnesota. They have a large Somali community. Communities are different within the city or state or across the country. So having plans and policies that reflect that are really important. And then the processes evolve, the solutions evolve. Things are constantly changing and improving, and being aware of that, which is what we're here for, but also the class standards, the culturally linguistically appropriate service standards really guide you so that you're not on your own to figure it out. Lots of people have done this before and continue to do it, and there's lots to learn from each other, but prioritizing it and really looking at it as, this is how I solve the first SDoH so I can access all the others and then really do whole health care. This is where you start. Okay.
Thanks, Danielle. Okay, so based on what we've talked about so far, who do you think language access impacts? So I want to ask you to type in the chat, who do you think language access impacts?
And if you can't see that,
okay,
Plug
we
them
see
into
it.
the questions pane.
Oh, yep, we can add it there. So ask in the question pane, who do you think impacts language access.
In case we don't get any folks, just because of the structure of the technology, who could we possibly imagine? Like if we had to list it all off, Tati.
Everyone is the first comment.
There you go.
Everyone, okay?
Patients,
everyone?
visitors, staff, patients and providers, patients, family, staff.
Right.
Okay, thank you. Yes, when we ask this question, typically what we obtain is the patient, the provider, maybe the staff, that's interacting with that patient. Sometimes people say family, yeah, the relatives of this patient. But I want you to think beyond that. Yes, it does impact directly the patient, the healthcare provider, even the interpreter that is, let's say, helping with communication during that interpret session. But it can go way beyond that. So think about your department, other hospitals, departments, and not just the one you typically work on in. So, for example, in your hospital and clinic, the patient experience department, risk management, your quality departments, your financial department, legal, compliance, all of those departments are impacted by language access services. If we have robust, holistic language access programs, the risks of having that impact in financial, legal, and other aspects, it's much lower than when we don't have, good, solid, holistic language access programs in our facilities. So in addition to that, think about also what happens. Oops, I skipped. Yeah, there we go. So think about even beyond the walls of your facilities. For example, have you thought of like the CMS quality metrics, for example, readmission rates, hospital acquired conditions, how not having equitable language access can increase the length of stay of any of these patients who need language services. Danielle even mentioned some statistics about that, and how not providing equitable language access can increase the penalties in your hospitals and clinics, or not give you all of the reimbursements that you would expect for your facilities, and how it also affects your communities. Danielle was mentioning something, and I have another example that I thought about, is that I used to have a neighbor who's deaf, and she would tell me, I am going to clinic A instead of clinic B because I know that clinic A offer video remote interpreting that I trust. So it's important to think about how not only this person wants to be seen and be taken care of by clinic A because of language access versus B. And not only she's taking her case to clinic A, if you think about this, she's taking her business. So think finances as well to clinic A instead of clinic B. Okay, so think about all that and how all of this goes way beyond that interpreted interaction, or way beyond the fact that I have to provide translated discharge instructions to my patients. How about what's happening once my patient gets home? Let's say ideally, we provided language services in the hospital, interpreters, we discussed discharge instructions with the patient at the hospital in the presence of an interpreter. We provided translated material. Now the patient has a question. What happens? Do we have ways for patients to communicate with the hospital if they don't speak English? Or if you already schedule a follow-up appointment and it's in the patient portal, are the patient portals in a language that this patient is going to understand? If this patient goes to your website, Is there any information there that at least Tatiana, the Spanish-speaking patient, could understand? So think about all of those things, okay? So more specifically, pass the slide here. We want you to think about all the different ways that, or the different strategies that you need to utilize when it comes to language access, okay? And we have listed here some of those. We've talked about interpreting. Yes, interpreting is key, and it comes in different colors, let's just put it that way, and we call them modalities. It could be on-site interpreting, remote interpreting in the form of video, and also telephonic. All of the three modalities are important. The more holistic is that approach, the better. And that means having the different modalities may be key to really address any language access needs. Now, we also mentioned translations, and the first thing that comes to mind is document translation. And yes, that is important, but you need to think beyond that. We talked about patient portal. We talked about your website. How about social media, your social media posts? Even some facilities provide like newsletters to the patients. Do we have that in other languages? HCAP scores, like the questionnaires. I believe in 2025, it's going to be mandatory to at least have it in Spanish, and maybe depending on your, the top languages other than English that are needed in your facilities, you may have to have it in other languages too, okay? And as far as I remember, at least 8 of those questions are related to communication. So I think it's important that your patients really understand what you're trying to ask from them. Another strategy is to really make sure your bilingual staff, and these are individuals who speak a language other than English, but they have been tested or there's proof that they are actually fluent in that non-English language. I live in Florida. In the area where I live, around 30 to 40% of the population speaks a language other than English. Wouldn't it be great to have, let's say in a hospital, around 30% of your staff vetted and ready, or what's called qualified, to provide services in that non-English language? I think that's ideal in many situations. Of course, if you don't have that, you rely on an interpreter. But if I can get care, receive care in my native language, that's probably better for me, okay? We also have different, and that's not to confuse it with, let's say, doctor who speaks French is now interpreting. That's a different role. That's actually what I'm going to mention now, the dual role staff. Many staff members are able to serve, let's say, as, the person who does triage or the person in admissions, and they're also interpreters for your system. That's a little more complicated type of approach, but it is something that many hospitals do and have programs on in this country. And of course, last but not least in this list is have all the documentation in place, starting with your policies. You need language access policies. You need a plan on how to execute, because it's a big operations to have a language service program, how you're going to execute all that. And then, of course, different procedures for your staff to follow, all the training that needs to happen in hospitals and clinics when it comes to language access. Danielle mentioned Section 1557 of the Affordable Care Act. Under Section 1557, staff in hospitals and clinics must be able to offer language access services in a timely manner. That means that they have to have all the tools ready, and they need to know those processes. They need to be trained on how to access language access services. And once they're trained and they have this patient coming in, they are ready to, let's say, access a remote interpreter via, let's say, an iPad or a different electronic, or they have access to a phone service and they know which number to dial, or they need to maybe request the presence of an on-site interpreter. Of course, that should happen ahead of time. So there's a need for a process on how to request an on-site interpreter, for example. Maybe it's a deaf-blind patient that's coming through your doors, and you need to be ready for that, okay? So those are different things that, strategies that many hospitals and clinics utilize here in the United States. I should add here also, make sure that you have a digital presence in other languages. That's part of, yeah, translation, but also not necessarily. So I wanted to mention it here as well. And it's also important to understand that this is not just the responsibility of the language service department. This is the responsibility of all of the departments in the facility or in the hospital system. It is the responsibility of the financial team, the executives, surgery, cafeteria, social work, you name it. Again, the departments I mentioned earlier, compliance, risk management, patient experience, all of those, because I see language access as soap, let's say, or language services as a tool or soap. In your hospital facility, you don't only buy soap for half of the bathrooms or half of the cleaning stations when doctors are going to perform surgery. You need to have soap available everywhere. And of course, you also have to plan on getting soap ahead of time so that you don't run out of it, right? And maybe there's no way to perform a procedure because there's no soap. So you need to think about language access services in a similar way, okay? Of course, it's a lot more complicated than buying soap, but I always like to share that analogy. All right, so it's important to all work together to be able to really provide language access services, because as Danielle said many times, it is the easiest social determinant of health to address and even solve, so that we can definitely focus more on what we need to do in our healthcare facilities, which is taking care of our patients, okay? So with that, I'm gonna pass it along to Mia.
All right, thank you so much. So now that you've had the opportunity to learn a little more about language access services and its importance, I wanted to highlight some of the key benefits that we as an organization can bring to you and your team. Like Tatiana mentioned, it is quite a complex lens, and that's where we have expertise that we can assist your organizations with. So first and foremost, medically qualified interpreters available on demand, ensuring compliance to all federal standards. All of our interpreters undergo 120 hours of training in order to be able to provide you that best-in-class, patient-centered care to the individuals that you serve. And then document translation as well. Tatiana did brief upon this a little bit, but truly medical translations are typically highly technical and often very sensitive in nature, requiring that specialized knowledge of the medical field in order to be accurate and then relayed appropriately back to those patients. Integration capabilities. So our interpreters can be brought directly into various telehealth conversations, and through our API process can also be automatically logged into multiple EHRs. Again, this saves both time and money and ensures 100% compliance, which obviously helps with the accreditation process that organizations like CIHQ does provide. And we do also provide, with our resident expert here, Tatiana, some consultative services and language access plans, which you just learned quite a bit about. And all data, all tracking, all interpreter interactions are reported, and all that data can be analyzed and logged back to your platform. So again, helping with that compliance aspect. If you want to move to the next slide. Okay, so as an organization, we do actually offer two different products, both with similar benefits, but that do differ ever so slightly in nature and their fundamental setup, because we as an organization understand that you as a facility have unique needs, and we want to be sure that we can meet those needs and sort of partner with you in the best way possible. So in the panel section of this webinar, you're actually going to see several brochures outlining more details about each specific product, both Marty and Voice. I won't dive too much into it now, but if you are interested in learning more, our contact information is provided in those brochures, and we'll be reaching out afterwards with some more information as well. Next slide. So just to summarize, the importance of language access cannot be denied. It is clearly evident and provides so many things to both patients and providers. And as Tatiana mentioned, anyone who has any relation to either. So to summarize some of the benefits of partnering with Equiti and some of the benefits of having comprehensive language access plans: better patient outcomes across LAP and deaf communities, reduction in patient readmission for those underserved populations, thereby reducing any risk and penalties associated as well, reduction in the average length of stay for a patient, compliance with all government regulations, which of course, again, will aid in that accreditation process with organizations like CIHQ, and reduction in overall cost while maintaining consistent best-in-class quality. And of course, just improvement in your workflows. Like Tatiana mentioned, everyone is involved, everyone is included. This truly is something that impacts every single individual at the organization. And with that, it's going to save both administrative and clinical staff so much time and ensure that they're able to do the work that they very much so need to do. And that is it from us. So we did leave some time for questions, comments, any follow-ups that you guys want. Like we said, you guys can put them in the questions panel right now. So yeah, thank you so much for taking the time today.
I will let everyone know this webinar has been recorded and will show up on the CIHQ YouTube channel. You can always email any of us for the handouts, and we're seeking questions. I'll leave the camera on until all of the attendees are dropped off. Thanks, ladies.
Yes, thank you.
Of course.
Happy to be here, happy to support.
Yeah. I'm going to stop sharing my screen now.
Sure. See, it's life size.
That way we can see, or the attendees can see our faces.
Okay. Lots of thank yous and great presentation. We'll hang on until the attendees are gone. Here's a question. Our patients have been requesting use of family to provide interpretation. We do this with the interpreter to assure we are covered. Your feedback on this, please.
I can answer that. So it's certainly understandable that a patient wants family. They think their family knows them the best. Maybe they've had poor interpreting experiences before at other facilities, and they think it's going to offer an extra level of security and comfort. What we often describe to the patient is that the family can't be family and interpreter. And the family needs to be family because you really need them in that role as family. Additionally, if they're not a qualified or experienced interpreter, there may be concepts or things that they have to interpret that may not interpret completely. And then all of a sudden there's misinformation, misunderstood information, because they're trying to wear several hats at a time. And it goes back to what we talked about earlier, communicative autonomy. If I'm a sign language interpreter and Tati's a Spanish interpreter, if we had to present and interpret at the same time, both things suffer. And so when families interpreting and they're not qualified, the language access will suffer, as well as the patient's ability to be present will suffer. And so when working with family that is really reluctant to let a professional interpreter interpret for them, we talk about the multiple hats you're putting on that one family member. And imagine if you're giving a really life-changing diagnosis, the family member who's interpreting is going to hear that first. And then they're going to have an emotional reaction. And then that family member is going to be sitting there going, what? And now that family member has to interpret, this is your diagnosis. And that can be an extreme case, but even in the smaller instances where maybe it's not as medically catastrophic, it's still putting an undue burden on the family member, as well as the undue burden of not being a professional interpreter in many cases. And even for professional interpreters who go visit the doctor with family, there's such a conflict of interest and a conflict of priority. Do I prioritize my sensitivity over communication, communication over being present? And it takes a little bit of communication and explanation, but we find that when we have that bigger conversation, and not just it's policy or sign this form if you insist, but talk about the implications that they may not have thought of themselves. Plus, it's for your own communicative autonomy, knowing that you're talking to the patient without filters of emotion and connection.
Yeah, and I would add to that is that if, worst case scenario, they continue to insist, and because I've been in that situation, the patient said, I would not speak if my daughter doesn't interpret. What you can do, and I think that's what you've been trying to do, you can have, it's your right to have the interpreter there. So legally, they can have anyone that they want interpret, or there's nothing to prevent them to have a family member to interpret. However, that's a right that all parties involved have. So even the medical doctor, the nurse, the social worker, whoever is the English-speaking person in this case, has the right to have an interpreter. So at that point, you may say, well, per our policy, I need to have a qualified interpreter here. Typically, interpreters are trained to do something that's called shadow interpreting. And in an instance, several instances, I've had to do that. So let's say sister of mom is interpreting, and I am the interpreter. I'm there. When I introduce myself, I tell them I'm going to shadow interpret. That means I'm going to be here listening to all the conversation. If I see that the conversation is not flowing, they're accused of misunderstanding or something, I'm going to jump in. And most of the time, actually all of the times that I've done this, I've had to intervene, meaning the daughter didn't know how to say a medication. This other doctor was speaking Spanish. He did a great job, but he was humble enough to say, interpreter, I don't know how to say A, B, C, and D. Can you please, now jump in? And that's what I did. So there are ways to, for the lack of a better word, cover yourself, but try to, the more you communicate with a patient and the family, the better. Okay. Any other questions, comments?
There was a comment. That is a great response to patients asking for family to interpret. Well done.
Thank you.
It's nuanced, like people. People and communication is nuanced and messy, and not messy in a bad way. It's just who we are. And so it can be messy when you're trying to figure out communication access, and there's that strain or conflict of well-intended, and the intention may not match the impact of that experience when you have family. And so it is worth having those conversations that you are sensitive to it, but really, as everything Tati and I said, there's a bigger part at play that we want to make sure we're sensitive to.
Mm-hmm.
Miss Annette said thank you. Thank you for your response. She had the original question.
Do we have any additional questions?
It looks like you get 15 minutes back to your day.
Wonderful. Well, thanks so much for the time.
I was going to mention something, and this is a question we typically get when we present. And it is like what to do when patients push back on a specific interpreting modality. And since we have Danielle here, I also want her input on this. Let's say a patient says, I want an in-person or on-site face-to-face interpreter versus a remote interpreter. So Danielle, if you can tell us a little bit of like how staff could address that.
Sure. So certainly depending on the language and the community and the needs, they're going to want an in-person interpreter. And part of that policy is that you hopefully have or will have soon is about a decision tree around when an in-person versus a remote interpreter is successful. Naturally, when you have a patient who's having, let's say sign language, for example, a patient obviously uses their hands to communicate and they've just had a stroke. So their hands are stuck down at their side. Really, this needs an in-person interpreter. Someone with vision impairments, or let's say has cognitive impairments, and focusing on a camera is just not going to work. Bringing an in-person is certainly necessary. In moments where someone's life is going to be, probably for the worst, dramatically changed profoundly, perhaps an in-person is better. But when you're looking at video interpreting over the phone interpreting, video reigns supreme. It's why actually you see the three of us on these calls. Besides the fact that I am a sign language interpreter and I feed off of facial expressions, I can't not have a conversation without seeing someone's face. It's just preferred. Imagine that's how your patients are feeling. That's how they're going to be able to communicate best, by the interpreter seeing all the body language and or the facial expressions. So much of our communication is not what we say, but maybe how we say it and our body language, catching comprehension or following the interpretation. You can get it on the phone. You get it better over video. And so we really encourage video whenever possible when working with a remote interpreter, because of all those facial expressions, body language, and that connection, right? We talked about how interpreters are a huge part of culture and understanding culture. We're not cultural experts, but we understand more than the average bear. And so we can pick up on some of those cues that will influence our interpretation, that will influence the rapport that's being developed between the patient and the provider. Phone works, but when in doubt or when possible, video for all of the other environmental cues that shape how we communicate.
Yeah, thank you, Danielle. And I would add to that that if patients insist, you may at least tell them, let's start, we want to take care of you, so let's at least start our conversation, or let me try to, start working on your care with a remote interpreter while we wait for the on-site interpreter. There are different ways to navigate those situations, so we want to make sure that you're equipped for all of those. All right. Any other questions, comments that came in while we were talking?
No, ma'am, thank you.
All right.
Thanks so much, Michelle.
Thank you to everyone who attended, and we'll be reaching out for any post follow-up as well. So if you do have any lingering questions, we'll be able to answer them then.
There is one new question. Are there any nuanced protocols in regards to telemedicine or virtual medicine platforms, specifically regarding quality?
Sure. So in working in those platforms, that really is integration conversations to first have between your language provider and your IT teams to make sure that ease of use, accessibility, availability is all sorted. But most importantly, no matter how or the means in which you work with an interpreter, over the phone, video, in person, telemedicine, beam down from the moon, no matter which way you work with an interpreter, the first thing to remember is that that encounter is going to take longer than when you're working or helping a patient who speaks English. And so it doesn't matter the modality in which you work with an interpreter, it just takes more time because you're working within two languages, two cultures, two different experiences. And so expecting interpreters to ask for clarification, normal. Interpreters who don't ask for clarification actually make me anxious because I'm not an expert as a doctor myself, but I'm a medically qualified interpreter and I may need to ask for clarification. Expecting interpreters to ask you to pause while they interpret. Heaven help the interpreters if they were on this call trying to interpret for both of us. I speak rather quickly. That can be really difficult. Expecting the interpreter to ask you to repeat something, totally normal. And so having those expectations in place as you go into telemedicine, as you go into a remote interpreting session, really helps calibrate so that no one gets frustrated when it takes longer than we expected. Now, lots of reasons why you're only allotted 15 or 20 minutes, and it can be harder to get that extra 15 minutes to make it work. But just that patience, knowing technology takes there's a connection there, and if they can't hear, depending on what platform you're using, sometimes a lot of noise from machines are there. If you have masks on, which we learned all about during the pandemic for everybody, can definitely have an impact. So that patience and expecting appropriate interruptions or pauses to do the work is normal, but the quality of the interpretation should be the same. It should be exceptional, high quality interpreters who are professional, adhering to national ethics standards, and making sure they're supporting the communicative autonomy of everybody.
Now, when it comes to quality of other aspects of that, or of how we connect with the interpreter, of course, well, sometimes this still happens in 2025 now, this still happens. We have, let's say, an interpreter that comes, or it's connected through an iPad, and then a telehealth doctor in another iPad or a computer, and then you have the patient in a hospital room. That is not conducive at all. So the more you integrate or have interoperability with your language services and your telehealth solution, the better. So for example, like the three of us here could be one the interpreter, one the provider, one the patient, okay? And they're in 3 different locations. When that doesn't happen, it's very difficult to communicate, okay? And in addition to that, it's important to have, Mia can probably talk more about that. I'm not an expert on that, but when it comes to like good video quality, audio quality, in fact, Section 1557 and ADA, the Americans with Disabilities Act, has specific guidelines on how video should be sharp, crisp, like, you should see people's hands and movements as best as possible. So those are the other like quality items that you should think about when it comes to providing remote services.
I'll add to that a little bit. As Tatiana was saying, yes, through our API process, and interoperability is so important in order to integrate the two, so you're not having that sort of a lag in communication or relying on putting up a phone to the telehealth or telemedicine platform. And that is something that we definitely excel in and can help you with. And the quality of the conversation that the patient's receiving should be consistent with if they were in a doctor's office receiving virtual interpretation like that through telehealth. That should be consistent across all platforms, and something we can definitely work with you guys on. And I also did see, Victoria, that you asked for a list of expectations, saying that it'd be helpful to share with your staff. We'll be sending over everything in detail afterwards, so you'll definitely get that along with everyone else.
And of course, if there are more specific questions or things that you want to talk to us about that are very specific to your system, you can contact us. I would say contact Mia first, and she would definitely get any of the, she will get input from us as well. We can certainly have a conversation about those things. All right. Any other questions or comments?
Another great information, and thank you very much. All right, ladies, we're down to the last 5 minutes. Any additional comments you want to throw in for the recording?
Well, this has been exciting. Thank you for having us here.
This has been great.
Yeah.
Thank you, Michelle, and thank you to everyone at CIHQ for working with us on this. We're a proud partner of yours, and thank you everyone for attending. We are really happy that you guys were able to listen today.
Outstanding. So again, I will get you this recording and we will upload it to the webinar page, the YouTube webinar page. All right, I'm going to shut it down. Thanks, everyone.
Bye,
Thanks, everyone.
Bye-bye.